We now continue with Healthy Longevity with special guest, Dr. Shelly Jordan.
Let's turn to inflammation in the immune system. You kind of alluded to natural killer cells, and we look at that as well. We look at immune function. I think in the end, it comes down to immune function in terms of aging. Like our system has to be strong enough so that there isn't this impact on the endothelium, which you say happens in the brain. I know happens in the body as well. It's kind of an end stage reduction of what diabetes and lipids and all of that do to your system. How does that work? What do we need to know about that in terms of protecting ourselves from decline and dementia?
So we need about a week to answer that question.
Yes, okay.
There's a lot of layers to that. So there's this concept of inflammaging. So the immune system ages in many ways, and among them is that there are these immune cells that get tied up in making a response to a particular challenge. For example, Epstein-Barr virus or CMV. These are viruses that you never get rid of. So you catch them somewhere during your life, Epstein-Barr often during teenage, CMV somewhere later in life.
And now COVID with the
COVID
spikes.
And the spike proteins. And even if you've never had COVID, just the vaccine.
I have given you the same thing. Right.
So now you have this chronic infection or infection-like process that your body's trying to fight off. And in fighting it off, it produces an immune response, which is toxic.
The senescent cells that lead to being zombie cells, so they hang around. They don't have they're not properly respectful and blow up and go away, but they actually sit there and they emit inflammatory.
They're angry. They go off of tumor necrosis factor. They give off all kinds of inflammatory factors, and that is affecting the brain. It crosstalks with the microglia, which is the resident immune cells in the brain. So they respond to this signal which is emitted, and they start chewing up everything. Good cells, bad cells, everything gets chewed up. Right. So this crosstalk between your peripheral immune system and your central nervous system ends up being one of the major factors, which is almost inescapable, by the way. When we do advanced imaging and we look at the signal of inflammation in the brain, that is almost uniformly seen after age 50 or 60. It is just so common to see that. And you have to figure out what's the source. Is there a chronic infection? Is there a leaky gut? Is there a dysbiosis, so the abnormal mixture of bacteria in your mouth or your gut?
Or your brain.
Is there mold exposure? Or in your brain. So
microbiome.
The brain has a biome.
Right.
So you have these human endogenous retroviruses, which we've had for eons, that are incorporated into our genetic code. And with a little bit of an inflammatory signal, they start coming out, and they make particles. They don't make complete viruses, but they make particles which are very inflammatory, and that can add to the whole process of degeneration. So we have to identify what all these different factors are and treat them.
How do we get rid of, I've just been presented with the case of a young woman who in college got Epstein-Barr. It completely wiped out her career course, and she feels inflamed all the time. It's very active. I looked at her immune system. She's not a patient, but she was reviewing this with me because it changed the nature of the work. She was going to be able to sing on stage, and she couldn't handle it anymore. She was worn out. And it reactivates periodically, as does cytomegalic virus. We follow antibodies for years. And we see the changes. And what we've done now, and I'd love you to hear if there are other solutions, is we're using therapeutic plasma exchange to wash the plasma, which I hope reduces the viral load and the antibody load that damages the brain, as well as you replace the plasma and you clean up the plasma to reduce toxicities, whether it's plastic, other toxic agents. And I wonder how it affects the immune system.
I think there's good data on plasmapheresis as standalone therapy. So, and specifically with mild cognitive impairment, there's this AMBAR study that was done that demonstrated that therapeutic plasmapheresis can be helpful. And it's probably doing some of the things that you're talking about, for sure. But there are other things that are happening in different layers. So let's say you have some Epstein-Barr virus, which is smoldering along and causing these zombie cells you were talking about. But the other thing is, it turns on some of the intracellular signaling pathways, and that acts on the promoters of these endogenous retroviruses that are in our genetic code. So the Epstein-Barr virus can trigger secondary viral type processes, which can then feed back to cause more inflammation. And you end up in this vicious cycle where some viral process that is going on sets up a chronic inflammatory problem. So you have to intervene. So you have to think about antibiotics for Epstein-Barr. You have to think about a variety of supplements and repurposed medications that can work on the inflammatory system.
Give me some idea, because, I mean, most people would say Epstein-Barr virus, why use antibiotics, right? You have a virus. How come an antibiotic is going to treat a virus when we're used to antibiotics treating bacteria?
Well, we're talking about, I should say, antiviral, antimicrobial agents.
Okay.
So I'm not sure what the best anti-Epstein-Barr virus antimicrobial would be. But I've been using valganciclovir or Valtrex.
Yes.
And I don't know if there's really good literature in saying what would be the best one to use, but I'll have someone on suppressive doses just like once a day.
1,000 grams?
Maybe just 500 of Valtrex.
I find that people break through with that, but I'm completely with you. If I see people get recurrent viral illnesses, I put them usually on Valtrex for a long time. I use myself as an example because my whole family would get cold sores, herpes viruses, and I'd break out at the light. I could feel it. And I have a pretty high suppressive dose, and I'm happy with it. There's absolutely no side effects.
So you're talking about herpes simplex, and there's been some correlation studies published about just herpes simplex and Alzheimer's disease. So if someone has herpes simplex, which is virtually ubiquitous,
right?
Why not be on Valtrex? 500 a day or even 1,000 a day is pretty safe. Mm-hmm. And maybe you'll run into some resistance from time to time, but it probably beats the alternatives.
I've never seen I have a low threshold for that treatment because I see the safety. There's a safety value. And I think we undertreat people sometimes. It's like Lyme disease, the same thing. It's in the same family. Lyme disease, Epstein-Barr, mono, cytomegalic virus, and now COVID. So practically every single one of us is affected.
Now, the other thing I do is I'll put people on an antiretroviral therapy. So I'll use lamivudine.
Really?
Because the human endogenous retroviruses are triggered by Epstein-Barr. So I'll put them on. That's also very safe.
What dose?
You use suppressive doses. I have to think of the doses there. I want to say it's 150 milligrams once or twice a day. There's actually a small study where they looked at mild cognitive impairment in Alzheimer's type pathway. Using lamivudine, they were able to show some benefit with it in a small study.
I'd love to try that. I think this woman might benefit.
Very safe.
Yeah. Well, the other aspects that I hear a lot of, and it seems to be triggered by the change in hormonal milieu and probably neurotransmitters, is migraines. I've had a lot of people present with vestibular migraines or strange brain activity, almost sounds seizure-like activity. They go on to be fine, and they function at a very high level, high executive function, and they have these conditions, and some of it's genetic, like they've seen it in their mother and their child already going through puberty.
Yeah, migraine in particular tends to be passed through the maternal line.
Cytomegalic, or is it
the
genes
I'm talking
themselves?
about migraine.
Just migraine. Yeah, I got it. But I meant in utero, is it the cytoplasm, or is it the genes and the genetic variants itself that you think carry the risk?
I don't know the answer to that.
Yeah, it's interesting. So those are some of the patients who would love to see you and talk to you about it.
Okay.
Hormonally, we can fix that, but we can't always fix the rest of it or understand the origin. So I'm looking forward to your brain studies because I think there are a number of people that we could help because they're unknowns. We can fix it, we can reverse it, but we don't always know what's going on and why. And
we can though.
That's what we want. So tell me how we can.
I'm going to show you.
All right. Well, that's for the future. That's the next podcast.
Well, that's perhaps the next podcast, but it's also something that we'll be working with you on and getting your patients access to advanced imaging. I think that with some of the serological tests that are available now, we can make predictions about people. I know the genetic testing that you're doing. we can make
and
predictions.
Biomarkers. Which biomarkers would you think are beyond ApoE4, which, by the way, is not just Alzheimer's, so there's a tie to lipids, because if you have ApoE4, you're also hyperlipidemic or have a greater risk. But what are the other biomarkers? Are you looking at ratios of amyloid 40-42 and tau and
so p-tau217 and A-beta 4240. You can also get neurofilament light would be a good way of. It's non-specific, but it's a way of looking at.
Which one is that?
Neurofilament light.
No, we haven't done that.
You can also do GFAP as well, GFAP. But they aren't necessarily super early. I think advanced imaging can pick up things earlier. But there's nothing like listening to the story. Like I said,
yes.
I'm kind of old-fashioned.
You're probably familiar with the book by Jerome Guperman, How Doctors Listen, and his story. He's a Harvard professor. I'm not sure if he's retired or he's still working, but he wrote a book that had a huge impression, and I had it on me, where he talks about the woman that presents to him is close to her deathbed. She's only in the 30s, and no one's made the diagnosis. From the time she was a teenager, they attributed it to being anorectic or depressed, and she would eat and eat and eat and gain weight, but still got worse. And she thought she was near death, and she agreed with her husband she'd go for one more test. And he had her charts in the corner that went up to the ceiling. And he sat down and he started getting her story. And that's why I don't think of a chief complaint. I think of a health story. I want your health story, which includes your family, if you know it, includes how you live life, the choices you make. And he sat there with her, and after hearing her story, he said, you don't have anorexia or depression, you have celiac disease. And that's underdiagnosed by a lot of folks.
Yeah, for sure.
And so that makes a huge impression, but I don't think we make the time for it. It's like in psychiatry now, there's a lot of drugs out there, apropos of your point of the pharmaceutical companies bringing them to market for billions of dollars and needing a return on their investment. But listening is one of the greatest skills that I think, compassion and listening is healing. And I don't think it's really available to most people nowadays. And I think AI may actually undermine it even further in some regard.
Perhaps.
Yeah.
But there's no substitute for listening to the patient tell their story.
Exactly. But I don't think people do that as much anymore. Is that your feeling?
Well,
you do, I do.
I can't speak for everybody, but I love sitting down and listening to someone tell their story.
Yeah. So you're curious like I am.
Totally.
I'm insatiably curious about people, and I remember their stories. I mean, I'd always remember their names, so I might need some help with that, but their stories,
We can work on that too.
Yes, I'm going to. I'm going to be signed up. I know you told me already.
You mentioned plasminogen precursor. I don't think our listeners will understand what that is, so maybe you can ask about supplements and also that.
Yeah, sure.
Explain.
Is that's the Dr. Prudhomme who does it in Southern California? Is he the one?
Dr. Goodnow is the one that
right.
brought one to market, which is called Prodrome Neuro.
Do you think it's effective? Because I've been listening to his lectures, but
we did a small study on it, and it looks like it's effective. I've had a frequent just clinical impression that when you put people on Prodrome Neuro, and including myself, by the way, you can make people feel more energized, more focused. There is a tendency for people, when they get to a certain age, not to make enough of this precursor, which your brain needs. It's made in the liver. And
like CoQ10, perhaps.
What's that?
Like CoQ10, coenzyme Q10.
Yeah, so it's produced in the liver, but it has to get to the brain. And the liver just stops making it at a certain age to enough of an extent to replenish. And so it's absolutely required, particularly for membrane stability. It's also an anti-inflammatory agent, but it's absolutely critical for the group of cells that makes acetylcholine, which is one of the major neurotransmitters that your brain needs. So if you don't have acetylcholine production, you get memory loss and a lot of other cognitive changes. So the plasminogen precursor is actually almost like a vitamin, because since you don't make it anymore, you need it in your diet, but there isn't enough in your diet. You do find it naturally in things like scallops and other seafood, but not enough. So you can take it as a supplement, and that can be very helpful, along with an omega-3 fatty acid, so DHA, EPA, phosphatidylcholine, also something that's essential. You don't get enough of it in your diet. So that comes in lecithin in the diet, but you don't get enough to actually give the brain what it needs to maintain its membrane integrity.
So that's good to know. We don't do all of that. We do much of it. So you're saying these are the kinds of supplementation that we should think about for everybody, but particularly those on a trajectory.
So you can do a blood test and look at how much of phosphatidylcholine they have, how much of the plasmalogens they have. So that can all be checked like any other lipid. So Prodrome Sciences runs that, and you can see what people have. And then you can supplement that.
Great. We're doing some of it. I don't know if we see every aspect of it, but that's something I'm going to take a look at as well for our patient population. So I've mentioned plasmapheresis. We've had a lot of success with it. We have people who I initially started on once a month for 3 months. The data that you alluded to in the research showed that if you do 2 plasmapheresis or therapeutic plasma exchange in 1 week, which cleans out, I would say, 80 to 90% because you're diluting it initially, but then we all have about 4.5 to 5 liters, and we are able to exchange about 2 to 2.5. That is the best outcomes. You do 2 in 1 week, 3 months in a row, you replace with IVIG or intravenous immunoglobulin, and we've had people do well into their 90s and requesting it again and again because they feel the difference. So that I myself went through it. And after a 3-month treatment, I reversed my biological age from the way we measured Dun & Pace and others by 15 years.
Yeah, I think there's good data in life extension, health extension, cognitive maintenance by using plasmapheresis. So I think that's an important aspect of every therapy.
I think the rate-limiting step is it's expensive and it takes a lot of time.
But I can do it once a year. The way that we use plasmapheresis, yes, it's detox to some extent, but we use it to remove. So this is in a clinical protocol that we're running at multiple sites, and what we do here is we do the plasmapheresis to remove the majority of the exosomes that are floating around. So a lot of this inflammatory signal that we're talking about is going to be encased in the exosomes that are floating in your bloodstream. What we're doing with this protocol is providing young exosomes from a placental cultured source and giving it to the biological clock of aging in the hypothalamus to reset that. But if you have your old exosomes floating around, that is competition. So when we beam an ultrasound at the hypothalamus to stimulate adhesion of the exosomes so they can be delivered to the site of interest. The young exosomes, the new ones. So young exosomes, right? We don't want competition from the old ones. Because what we know, this is an experiment that was done many years ago, Valleda and other people have published this in Nature and a series of articles after that. If you take exosomes from an old mouse and you give them to a young mouse, and then you look at the brain of the young mouse, it looks like an old mouse. It actually kills some of the stem cells in the hippocampus, as well as other parts of the brain. And even if you do this in culture, if you take cultured nerve cells and you take exosomes from an old animal and you put it into the petri dish, you actually kill the nerve cells. So we don't want that around.
No.
So what the ultrasound does is it basically forces the exosomes that you're giving to go into the area of interest.
But first, you get rid of, the ultrasound is non-invasive. Do you first get rid of the old exosomes by therapeutic plasmapheresis?
Exactly.
I see.
So if you do a total plasma exchange, you're getting rid of more than 70% of the circulating exosomes for a certain number of hours. Most of the exosomes are made by white cells. And we were talking about these zombie cells floating around. So they're giving off exosomes that you don't want. So you want to get rid of that first. And once they're gone, then you can give fresh exosomes.
And you just infuse them systemically or IV?
Mm-hmm. IV. And the ultrasound will turn on the adhesion molecules in the target zone. We published this in Nature a couple of years ago. So this is not fanciful thinking. We can actually demonstrate we can do that. You can get 50% of the payload that you give intravenously. So 50% of the exosomes you give intravenously will end up in the target zone. So if you want to get those exosomes to reprogram the biological clock of aging in the hypothalamus, you can get them deliverable non-invasively, giving the exosomes intravenously, but using the ultrasound to get them to go to the place of interest.
Fascinating.
But you have to get rid of the old exosomes first, because then you have competition.
You don't do two. It's like, to me, the 2 TPEs, or 2 therapeutic plasma exchange, would remove the vast majority, like 80 to 90%, because you're initially replacing 2 to 2.5 liters.
Yeah, but only for hours.
Okay, so
when we're talking about exosomes.
So only do 1 transfusion, even though you're getting only half the plasma that you need, and then you're expanding it with albumin?
You do a total plasma exchange. You replace with albumin. There'll be enough immunoglobulin around. If you want to give extra immunoglobulin, you can, but we haven't been doing that. We do this no more than once a year, which keeps the cost way down. So what you're saying about frequent plasmapheresis makes a lot of sense, but it's costly.
Yeah. Well, I wondered, and you say you have to do it within hours. I've been treating some people who come back for 2nd and 3rd round, 2 a week, sometimes one day after the next. But if it's hours, what's the room for maneuvering with the ultrasound and the treatment with exosomes?
Oh, so if you do the plasmapheresis first to get rid of the old exosomes, you have several hours to give the exosomes.
Okay.
There's a window of opportunity. After a certain number of hours, these white cells, they're still floating around because you haven't taken them out with the plasmapheresis.
Right.
They'll start recreating that mixture of exosomes, which are inflammatory.
Got it. So you don't think so it doesn't sound like it's possible, but maybe we can study it, doing 2 therapeutic plasma exchanges within a 24-hour period, and then doing it might get rid of even more of the negative cells.
You could do it as a single plasmapheresis and make it like 1.5 plasma volume. So I've looked at the pharmacokinetics here. If you do an extended plasmapheresis, so rather than, let's say, 2.5 hours, it'll be more like 3-4 hours, you can get rid of perhaps 90% of the old exosomes. But again, that's more cost, because now you have to replace with more albumin, and so it gets to be costly. So I'm trying to keep this inexpensive, accessible, and workable. So we now have a multi-site clinical study that we're initiating with permission from the FDA and the IRB that's involved to reset biological age using exactly this process, but only a single plasma exchange. And
for like a 2 hours, or let's say 2.5
hours, yeah. Then we do the ultrasound. Then we give the exosomes. You have a window of opportunity. Then we may follow with one more ultrasound treatment, and that's it. So the whole thing is over the course of like 4 hours.
These new sources of secretome from stem cells that have exomes might be interesting. It's autologous. It's cultured. Again, though, I don't know if the age of the individual and the fact, that it may be not as young as you want it to be.
That's the problem. But there's some really interesting things that people are doing. So they're reprogramming your own and rejuvenating your own stem cells and exosomes. So Dr. Giampapa and other folks that I've worked with have done this co-culture type of technique, where you have a batch of your stem cells and a batch of stem cells taken from placenta separated by a thin membrane. Well, they start exchanging things, including potentially exosomes and other growth factors. And it turns out, not that we care so much, but the young stem cells get older. That's okay. We're throwing those away anyway. Right. But the good news is that your old stem cells can now be rejuvenated, re-educated. And so now we can culture those and get a better set of exosomes. Or if you want to use the stem cells themselves, you can use those, and now they're younger.
Right. Well, that's amazing. I would like to think about that. There's a lot of work going on in optimization in the world, longevity, optimization, health span, that we've kind of focused on for years of our career, but now it's become hot, possibly induced by podcasters, and influencers, or just by the fact that COVID really did a number on a number of people, and they knew comorbidities is not a good thing. So people have focused on health. They're living longer. We're living longer. How do we stay healthy till over 100 instead of declining, stroke, dementia? What do you think of some of these brain optimization centers? Are you in favor of it? Do you have any concerns? What do people have to look for if they're, because, for example, you see them all offering NAD, infusions. There are aspects of it that I feel by perception, it's hard for the public to know what's good, what's not good, what's dangerous, what could really make a difference. Any thoughts on that?
Many.
You want to share any of them?
So, of course. And that's a great question. So how does a layperson figure out what makes sense in terms of an integrative and functional program? I think number one is the person needs to take out the guesswork. So you were alluding to this before. Not everybody's the same. So a twin might be different. A sister or brother might be different. But certainly people from different families are very different. So you can't have a protocol that is good for everybody. So what that means is you have to have the right set of tests available to figure out what system needs to be optimized. Because if you're going to give 50 different supplements and medications, it ain't going to work for the average person. It's going to be very poor compliance. Who knows how these things start to fight each other, and it becomes expensive. I have patients that come in with a batch of supplements like this. You probably see this all the time.
Yeah.
And they're spending several $1,000s a month.
Yes.
Do the math. 12 months a year, it's a lot of money, and they may not need any of them, or they may just need 10 out of the 50. So the first thing that a smart consumer would look for is, what are they doing to figure out what system is optimized? Is it mitochondria, the fuel-producing component? Is it loss of stem cells? Is it a problem with the microvasculature? Is there inflammation? What's the source of the inflammation? Is it early stage diabetes? Is it a hormone imbalance? All of these things need to be identified very clearly in a personalized way. That's step one. So if they don't have that, go to a different place.
Right.
Number two, do they actually work on that data in a way that is scientifically founded? There's a lot of crap out there. And this kind of annoys me, that certain people will make observations and recommendations based on no human data.
Or no background in medicine.
Or that as well.
Right. Because it's a hot thing to get biomarkers. Almost every company now offers biomarkers, but there's no way to take it to the next. So you get your biomarkers. What does that mean? All
right. Well, let's say you do some testing and you find out that the microvasculature is failing in the body. And with serological markers and advanced imaging, we can figure that out. So what do you do next? What choices of supplements, repurposed medications? What is the science behind it? So I would insist on evidence-based medicine. What that means is, to me, is that see what's out there and make a choice based on what actually has some scientific backing. And I think a layperson should start asking questions. Okay, you're going to give me nattokinase, for example. What's the human data? Yes, it seems like it's cool. Seems like it can dissolve fibrin. And it seems like that's a good thing to do. But how about the fact that when fibrin gets into the brain in early Alzheimer's disease, it's in the interstitial spaces. It's not in the vascular compartment where nattokinase can do the work. So does it really do that? Where's your evidence?
Yeah.
Tell me why it should work. So don't tell me like, how many patients have you treated? Do you think they do well? Because there's placebo effects, as you well know.
Right.
So show me the science. Give me the research papers in humans that shows that thing that you're recommending actually does the job. Third thing is, the supplement or the medication they're giving, is it tested by third party?
Does it actually have activity? What kind
Exactly.
of activity? Is it absorbed and metabolized?
Does it have it?
Right.
So I'm going to harp on nattokinase because it's a nice catchword. So is there any in there? So this supplement that you got from whatever store, or maybe you have some deal with a compounding pharmacy, who actually tested to see that there's nattokinase in there and is it in an active form? And by the way, does it even get into the body through the gut? Do you have to inject it? So all those things should be asked. So what's in it? Is there scientific evidence? And is it for me? I want to know what system is failing and do I actually need what you're recommending. So I would say that those are the three things that I would look for. And I would make the prediction, you're going to say the same thing, I know that. I would make the prediction, if you ask those three to 100 doctors, you'll come up with a small handful that will satisfy all three.
I think that's optimistic. Because I think when something's a trend and when people hop on the bandwagon, they want to believe they're doing well. And people can respond because of the placebo effect, at least for a few months or a year, or the belief that they're doing something. Belief alone is sometimes
I would put on a
good
wolf outfit, shake a rattle, and dance. It would make people better. But I shouldn't be charging $50,000 or $100,000 for it, right?
I agree.
My wolf dance is cheap.
Yeah.
All right, if it gets you better, fine, but I'm not going to charge you $50,000 for it.
And prayer is good too. That works. Group sessions
Absolutely.
work. But I started this with that very intent in mind because I saw the abnormalities beneath the surface at the cellular level, metabolically. And and got the stories, a 30-something or 40-something year young woman or man, and they're telling me their mother died of a massive heart attack, their father had angioplasty, now has osteoporosis. What can they do at 40, 45 to keep themselves intact? And I would look at their numbers and see they were already pre-diabetic. They already had changes. And when I presented it, I was told, this was in the old days, you're going on a fishing expedition. Why are you doing that? And I'm saying, no, there's real abnormalities here. Their trajectory is to get sick, and look at their family history. Who do you think they inherited it from? So I set this out prospectively with an N of 1 design to say, okay, can I detect patterns? And really did it under a protocol, driven by a protocol, which I still have approved, where I could publish anything, because I made it very global, having done a lot of studies and research. And to see that I can identify. Now, if I talk to someone, I can identify what they're struggling with just with a lead-in intake to make sure they're a fit and they understand how we work. Because we're not someone you call and say, I'm making an appointment, can I come in next week or the next week? No, I need you to understand why we're doing what we do. And I need to know that this is something, A, that you're not at high risk, and B, how do we really help you? Can we help you? And are you interested in this approach? So I completely 1,000% agree. And it's hard for people to understand that because they're looking for hope. They're looking for help. They may not feel well, or they may see their friends doing great because they're getting infusions of one sort or the other that probably have caffeine in it. So it makes them feel that they're good. And it's a tough situation now because I think there's too much of a good thing. How do we discern what's really good and what's not so good, That's really difficult. All right. I think that we're getting close to, if there's something you want to add that I missed, I would love to hear how people might reach you. But I have one last question, if that's okay.
Shoot. So
everyone finds out you're a brain doctor, either at a party in LA, wherever, or on a plane or a trip because you love your work. You've done made amazing advances in life, and particularly for the brain. And they ask you, well, what can I do? What's the one or two things that you'd recommend me starting today, tomorrow, so that I can optimize my brain and reverse aging? Okay,
so I think there's some things that make a lot of sense. And we actually talked about some of these. So this is kind of a summary statement also. I think, first of all, knowing your genetic inheritance and what you might be at risk for is definitely a good way to start. Knowing what makes a good diet, how to cook your food, how to source your food.
How to find good food given the soil is damaged and there's no nutrients in food.
Absolutely. But also, how do you control the air you breathe in your house? How do you control the water that you drink in your house? So controlling your environment, controlling your food, controlling what you drink, controlling what you're drinking from, like plastic cups.
Well, this is glass, but
you got a plastic top.
I agree. Yeah, I thought about that before.
So these microparticles get into the brain. So controlling your environment, controlling what gets into your body, absolutely critical. Exercise, enormously important. It can't be overestimated. So everybody should have a resisted training program. And it doesn't have to be every day. Maybe it's better to be 3 times a week or something like that. But you want to feel the burn. You want to work out with resistive training. And that burn is the muscles really being stressed, which is what really gets them to develop. So that's really important. Optimizing sleep. I would suggest there are so many good home devices wearables that can be obtained now. I don't know if you want to name particular brands here.
Sure.
I tend to use an Oura Ring.
Here I have.
That's been.
They used our site to show medicinally why.
So it's been cross-correlated with formal sleep studies, and it's not bad. It's not perfect.
Well, formal sleep studies always bothered me because you're taking someone into an environment. You're tying them up, they're sleeping in a place they don't know, and mostly they come up with sleep apnea. There's very little else you see in it. So I like the home studies, which are now available. Yeah,
there are home studies. There are some companies that will have programs where you can do it at home and mail it in and get a
Blue
pretty
Sky,
decent,
I think, is one.
Onera is another one.
Yes.
So we talked about controlling the environment, diet, what you drink.
So it's the way you live life sleep, that you're pointing to.
Those are all important. And, I think there's also some other factors that some people see as intangibles that turn out to be very important and turn out to be substantiated by scientific research. So spirituality. So if you look at outcomes, people who have a spiritual practice, they do better than people who don't have a spiritual practice. People that have a family support system turns out to be very important. Those loners in the world don't do well. The people that don't have a meditative or spiritual practice don't do well. So that's often not emphasized by doctors, but doctors need to be thinking about
There's
this.
studies out of Penn that I remember reading years ago. There's a lot of studies, but if you went home after a heart attack and you went home alone, you were going to die quicker than if you went home to a significant other, like a human. You actually live the longest if you only went home to a pet, because it's unconditional. And there's lots of studies about surviving metastatic cancer in group sessions where you can share the experience that were done, both starting at Columbia and then taken to Stanford.
And the last thing that I would highly recommend is youthful energy. So I think the worst thing you can do in life is to sit around with some old folks and complain about health. I think that is toxic. So these memory care centers and these rest homes and assisted care programs, I'm not particularly thrilled with them. What I really like to see is people who might be retired get into some community service, get into some extension course in a local university.
Exercise your brain,
but be with young people.
Yeah. Or give back to young people, bring them along.
Be a teacher, be a mentor.
Yeah, exactly. I've said that to a lot of my patients. They have communities around the world where they've set them up for people that have already lost the mild cognitive deficits or Alzheimer's or dementia, and they actually treat them as if they're full members of the community, which keeps them going much longer.
Totally.
Or if you keep a person in their own home so they're not disoriented and you provide resources. Of course, all of this costs a lot of money and a lot of planning, and I think we're very excited about it, but putting it into practice, I think, is still challenging.
You can volunteer for a whole variety of community services.
That is easy.
Yeah.
Give back and feel good, and then you get it back, so
yeah.
I agree.
That's better than talking about the colonoscopy you just had with your neighbor. It's
Yes.
it's much more productive.
How do people reach you? So the listeners are all going to be excited. They want to make their brains young again.
Well, my main practice is in Santa Monica, California. So it's Shelly Jordan, and I'm listed. I love what I do. So no way I'm going to retire until my wheels fall off, because I'm having way too much fun. And really, when you think about it, what's more important in life than making a difference? And, that makes it worthwhile to be here. And I'm going to keep doing that as long as I can.
Well, you're making a difference for a lot of people in the world. So I thank you, and I'm looking forward to working together with you.